looking for some sort of a benefit for wearing C-collars, and none was to be found.
If you brought somebody in that had any sort of a mechanism of injury and you didn't have them fully spinal mobile restricted, I mean, the doctor was chewing your butt out.
You are listening to EMS with your hosts, Erik and Matt Ball.
You look pretty uncomfortable there, Matt.
I'll give you two guesses what we're talking about today, and the first one doesn't count.
Love it. I love it. Can we help you with that?
Yeah, I got it. Thankfully, I don't have a spinal cord injury.
Yeah, so spinal cord injuries are pretty common. In fact, spine injuries are one of the most common causes of traumatic injuries,
Yes.
Usually with blunt trauma. It makes sense that penetrating trauma, penetrating trauma through the neck is different, but, typically penetrating trauma doesn't injure your spine unless it's direct, right? But blunt trauma, though, you get that whiplash.
Yeah. MVAs, falls, those kind of things. But before we start, make sure you follow our podcast, follow our YouTube channel. Helps us out with getting this information out to more people. So make sure you do that. And we're talking about C-collars and spinal immobilization or spinal mobile restriction because of a paper that came out last month.
That's right. Yeah, it challenges the standard of care has been in most municipalities. You get a trauma, put a C-collar on.
Oh, yeah.
We've gone away from the backboards.
Yep. About 10 years ago. Depending on where you're at. Yeah.
Yep. And it does address it in the paper. Backboards are useful for extrication, and there are certain situations. Yeah, we need them, but they're not the standard of care anymore.
No, and I think this is good news. I think first off, it's good for the patients because hopefully we're not going to be unnecessarily making our patients uncomfortable or causing more harm, as this paper suggests, by putting them in these uncomfortable collars.
Right.
I think anybody that's been doing this for any amount of time, these collars hardly ever fit correctly. I mean, I wore that thing for about 2 minutes, and I don't have an injury, and I'm sitting up, and it literally does. Patients would always complain, I feel like I'm choking. It literally feels like it's choking you.
I've seen these things placed backwards.
Oh, yeah.
I've seen them sideways, up over their faces. I mean, it's just
they don't ever fit. They don't ever fit right. They make the patient super uncomfortable. Half the time they ask to take them off. And so I think it's a good thing that, again, this paper is saying the data shows there's no benefit.
That's right.
And actually might be some negative outcomes to putting patients in C-collars.
They looked at 4,000 pieces of literature, and nowhere did they see a statistically significant benefit to wearing one of these things.
Right.
Remember, it all started back in the 40s. There was a hypothesis. Well, that's not true. It really started because we noticed anecdotally that people had these post-incident sort of neurodeficit, get paralyzed after the incident. So what caused it? And the hypothesis, which is reasonable,
It is.
and it's logical, that motion caused the complication, the secondary injury, right?
Yeah.
And so that was the hypothesis back, I think it was 1944 in the paper, if I remember correctly.
Yeah, I think it was, we've got it right here, Howlett. I think it was the World War I or World War II is when he created this hypothesis.
That's correct. And a lot of people, and it makes sense to me too, we didn't have the imaging studies we do today.
Sure.
So back then it made sense logically, and I think it makes sense today logically, and it's not unreasonable to have that as the hypothesis to why these secondary injuries occurred. But it wasn't until, I think it was Gordon, was the next one, I think, if I remember correctly.
Rogers.
Oh, sorry, Rogers. Yeah, that's right, Rogers.
1957, yeah.
Yeah, he agreed with that hypothesis, and he saw anecdotally a bunch of his patients with these secondary neurodeficits, and he had developed some sort of a spinal motion restriction device, which created some bias for him.
Yeah.
But the problem was the American College of Orthopedics and the American Medical Association backed him, and it became the standard of care.
Yes.
So for decades, I mean, almost
longer than you and I've been alive, and we're two old dudes.
We're getting close to a century here.
Yeah,
right? You know, is the standard of care has been to throw a C-collar. But over the last few years, we've been challenging that. Since the spinal motion restriction with backboards, I think we've been questioning these crazy things. And this paper went out there. I'm just going to read.
Yeah. Yeah, this wasn't a paper where they had like a control group and all that, I don't know all the technical terms you do, but this was a paper where several of the authors of this paper looked back through 4,000 different articles, correct?
Almost 4,000.
Almost 4,000.
3,944 articles.
Yeah.
Manuscripts.
Looking to see if there was any data, correct me if I'm wrong, any data that proved that there was a benefit, one, that there was a benefit to C-collars, and two, that movement caused a secondary neurological injury.
Correct.
Does that pretty much sum it up, what they were looking for? And
this is powerful evidence here. This is called
Yeah.
a meta-analysis. And
Yeah.
this is, now none of the evidence that they looked at was, the best kind of evidence is randomized controlled trials, right? But a step above that would be this meta-analysis thing where you're looking at thousands of manuscripts and data, looking for some sort of a benefit for wearing C-collars, and none was to be found.
Zero. Not just there were a few, there was zero data or information found in their research that showed that there was a benefit. Number one, that there was a benefit to C-collars, spinal mobile restriction, and that secondary injury. Actually, they found that putting a C-collar on can cause damage.
That's what I was going to say, is that not only did they not find benefit, they did find, and I think I've heard 50-something incidents here of documented and statistically significant harm to patient and to, by the use of these C-collars.
Yeah, respiratory depression, putting these patients in a C-collar, laying them flat, caused respiratory issues, decubitus ulcers.
Even data to suggest that wearing a C-collar actually is counterproductive to decreasing motion.
Right, yeah.
So there's a lot of evidence out there, and there was no evidence of benefit, but there was evidence of harm.
Right.
So in the conclusion here to the article, now, most people when they read papers, because of time, they just look at the abstract. There's a lot to be seen in this paper, and you and I dissected
perused it.
Yes, we really took a strong look at it, and there's a lot of other data out there too that we looked at. But I thought it's interesting, and this is I think in the conclusion here, given the lack of data supporting clinical benefit and the extent of data demonstrating the evidence of harm, spinal immobilization and SMR should not continue to be upheld as standard of care. So that is specifically related to C-collars. That's a pretty profound statement, and I think certainly appropriate to talk about today. And we kind of mentioned it earlier. The hypothesis was motion caused harm.
Well, and if you think about it traditionally, like what do we do with any suspected bone fracture? We splint it. Legs, arms, whatever. We splint it up. Heck, we used to do the sandbags or saline bags. If they had a flailed segment, you would. The whole mindset was splint it. And now, and again, you got to think EMS is relatively a new area of medicine, right, in the grand scheme of things. And so they're looking at a lot of the things that we're doing, and they're getting more and more data in. And so that's why so much of this is changing, is because they're seeing the data going, oh, this has benefit or it doesn't have benefit. And so this is one of the things that has been a staple in EMS and emergency medicine for, like you said, decades.
And they're expensive. Not only are they hurting patients, they're expensive. We're spending a lot of money on them. And, I just read this recently, $443 billion we spend in the U.S. annually on traumatic injuries.
Right.
And one of the more common traumatic injuries is spine injuries. And it was interesting, I read that...
now, is that the most common actual injury or the most suspected
I think
injury?
The most common injury, well, it's a good question. The mechanism was falls. It's the most common.
Right.
And when you fall, obviously traumatic brain injuries were high, which were often associated with potential spine injuries. But the actual spine injuries were not the most common thing, but relatively common. And when you're talking about, the number of people that are involved in traumatic injuries, I think the number was 1.7 million. And I think it worked out, gosh, I don't quote me on this, but it was, I think, 800,000 people. But all that to say, a lot of people get C-collars placed. But what was interesting was, and this is one of the harms brought up in the paper, was that when a patient comes to the emergency department with a C-collar on, between 88 and 94%, based on different studies, but the vast majority of them get a CT.
Sure.
They get irradiated. They get a CT scan, even though the likelihood of injury may be low. They still got that CT scan, which is harm to a patient when they didn't need it. And the data suggests that 88% of patients who are wearing a C-collar don't have an injury, and 12% do potentially.
Right.
But those that do have an injury shouldn't necessarily be wearing a C-collar anyway, because it's just causing harm.
And that's so the theory again was the movement is what was causing the injury, and
that was the hypothesis. That was the theory. Yeah,
exactly.
That's right.
And now they actually are saying no, it's hypoperfusion that's causing the injury or causing the secondary neurological.
Just to be clear and to just be fair,
right.
There really isn't a lot of data out there.
Right.
Backing up this hypothesis, but it does seem to hold true. We know about spinal shock. We know that injuries to the spine, when we don't get blood flow, can cause subsequent damage and secondary injury. And that, to me, I agree with you. I think we can't say that it is what it is.
Right.
But we know it does not appear to be, based on this data, motion.
Right.
And I agree with you. I think it is hypoperfusion that causes those injuries. You get a patient with a spine injury, and then lack of blood flow to that injury is what's causing those subsequent deficits that we've seen anecdotally.
Yeah. I think it's good to talk about the evolution of this whole spinal, immobilization. In this paper, they kind of talk about it. But like when I started in EMS 20 years ago, it was anybody. I mean, this was something, everybody that's taken National Registry skills exam in the last 20 years, EMT or paramedic, you go into your trauma thing and it's like, if you don't immediately get C-spine, you fail, you're done.
That's right.
It's a hugely pushed mindset within EMS, is that if you have any trauma patient, you have got to get C-spine, you got to get the collar on you. And back again, when I was going through school, it was C-collar, it was a rigid backboard, you get the headbed out. I mean, you strap these patients to a hard board, you get them on your cot, and they're bouncing down the road like a corpse on this cold, hard board, especially little grandma, right? And then we did that for about the first 10 years of my career with everybody, right? And if you brought somebody in that had any sort of a mechanism of injury and you didn't have them fully spinal mobile restricted, I mean, the doctor was chewing your butt out, for not doing it.
That's happening today.
Yeah, that's what I'm saying, is that there's probably still areas right now that this is still part of your protocols. And if it is, if you're still using rigid spine boards and, strapping people into these long boards with C-collars on.
Hopefully not the rigid spine boards, even the vacuum splints.
I mean, that's what my department currently carries, is the vacuum splints. But if you still using rigid spine boards for more than just lifting purposes, and that's in your protocols, you need to talk to your medical director. Like, you've got to talk to your medical director. There's science that backs up that is very harmful, much more harmful for your patient to transport them on a board as opposed to not. They didn't fit right. They didn't fit around the holes and the barriers in the body. So we got rid of those like 10 years ago, in my department. They said these don't work. And then we went to, okay, we're only going to do, and again, this is just my specific protocols, where if they had like pain, like if you're doing a head to toe exam or they're complaining of pain in their neck, or if you're doing an exam and you're palpating and they're like, oh, my neck hurts, then we would spinal mobile, we'd put them in a C-collar, have them on the cot. We'd usually have them sitting up at about 30 degrees, and that's how it's been for about the last 10 years, where we would only use, now we have the vacuum mattresses, but those can be moldable, which is better than the hard spine boards. But that's pretty much been the standard of care for a long time.
Oh, yeah.
And it's kind of scary.
Well, it still is. It seems to be. It's still lingering, this whole C-collar thing. I will confess to you that it used to be a critical action on my checkoff that I'd do. When I had a trauma patient, one of the checkoffs was the C-collar.
Yep.
I'm thinking of a specific case right now, the motorcycle accident. That's one of the things they had to do.
Sure.
It's no longer there.
Yeah.
It's no longer there. In the NFL, we go through training, mandated training, all about spinal immobilization.
Really?
It is, yeah, and it's happening today.
Yeah.
And so it's there's a lot of value in challenging the null hypothesis. And for decades we have not challenged it. It's so logical, and it becomes such a checklist on what we do for trauma patients that we don't even question it anymore. In fact, in the hospital, not putting a C-collar on a trauma activation almost seems like I haven't done my job.
Yeah.
But we need to really rethink these things.
It reminds me of when we first started talking about not doing chest compressions immediately on trauma patients, right? I remember being at a fire department.
Pulseless trauma patients, yeah.
Yeah, I'm sorry, thank you. Pulseless, a traumatic arrest patient.
Let's be clear.
Good clarification, yes, yeah. Yeah, a traumatic arrest patient.
Yeah, sure.
When I don't know how long ago it was, 4 or 5 years ago. And we were teaching this mindset of, because for so long, it was they're in cardiac arrest, you've got to get on the chest, right? So we pounded that into our folks' head. And then we're coming back and going, well, wait a minute, hang on.
So you're telling me not to do chest compressions on a pulseless patient?
Exactly. That was exactly the statement.
Been there.
Yeah, I teach in the class, and this came out, and I was like, we're not saying don't do it. We're saying it shouldn't be the first thing that you do right away on a trauma patient. Yeah. And that was exactly the response of one of the guys that was in one of my classes one time. He's like, what? Are you telling me I'm not supposed to do CPR on somebody without a pulse? And I'm like, think about what you're doing. Like, think about what has happened to the patient, right? And this is another thing. Like, I can just imagine going into a fire department or a private EMS agency doing a class and saying, hey, you can take these and throw them in the trash. And we're not saying, do that yet, but it's probably coming.
Well, we're going to get to that.
Yeah.
I look forward to talking about what I have planned, in our department as we phase these things out, and the way we're going to handle it.
Yeah.
It's probably going to be a bit of a hybrid initially, but it's going to be gone.
Yeah. No, that's good. I know I've already talked to my medical director, and I would encourage everybody. I will put a link to this paper. I'll put it on. It'll be in our link tree. I'll put it on the YouTube video if you're watching this or listening to this on YouTube. So, like I said, it just came out last month. So, if you're a pre-hospital provider, EMT, paramedic, if you're a registered nurse, listen to this. If you're a physician listening to this, forward this on to your medical directors, because like I did when we first got this paper, I sent it to him and he read it and he's like, this is interesting. Yeah. But then, he was talking about, which was interesting coming from a medical director's perspective, was that, when you're the first one to do stuff, that can be difficult. And sometimes people, without much buy-in, you can get nailed to the cross sometimes on, what are you doing?
Well, when you and I were working on the OMI stuff, those 12 EKG patterns that we haven't historically really looked for and we haven't recognized as STEMI equivalents. Yeah. We're not asking people to throw STEMIs out the window.
Right.
We're just asking people to open up their eyes a little bit and consider the fact that there are other patterns we should be looking for to be emergently revascularized, right?
That's right.
That's really what we were doing. It's like we're expanding the definition of what a heart attack is.
Yeah.
That was difficult to just expand our view.
Yeah.
What we're doing here is this different.
Oh, yeah.
This is
you're taking them away.
Yeah,
we are no longer, again, something that has been a staple in EMS for decades is we're not maintaining C-spine anymore. Now, that's not saying that you're letting the patient, which that's what's always been funny to me, is when I put one of these on a patient, they're sitting there pulling at that collar and they're moving we're causing them to move more by putting this uncomfortable collar on than it would be if we just put them on the cot and said, hey, try to keep your head still and stuff, but they're comfortable. I think we were causing more movement with this. It was counterproductive to what it was trying to do.
Now I'm going to say something here, and I think it's important. I got to hear our former Surgeon General, U.S. Surgeon General, talk about spinal injuries, and he actually took a preserved, C. Everett Koop was his name. He's no longer our Surgeon General, and I don't even think he's alive anymore, but he took a preserved spine and attached levers to it to try to dislodge it and separate it, and he couldn't do it.
Really?
could not do it. The spine is a pretty durable, tough deal. Now you can injure it, obviously. You can fracture, you can do things, but it's when we get injured, we have a spine injury. We actually have a natural sort of a protection device. All the muscles around the spine constrict to almost protect the spine.
Yeah.
And that I think can contribute to part of the problem with hypoperfusion. With the evidence, we need to study these things. But the fact that we think that this is going to stop an injury from occurring, if you just step back,
think about it.
Some of the complications of wearing this device are hurting patients, and it really doesn't make a whole lot of sense. With this, there are some unstable spine injuries out there in certain situations where these may be warranted, but to think that this is going to prevent injuries from happening, I think that's pretty archaic, and clearly based on the evidence, I think it is a harm causer and it does not produce any sort of a benefit.
Right.
So pretty straightforward.
Yeah, I think so. Well, let's take a break, and then we'll come back and talk a little bit more about this new data.
Sounds good. All right, Matt. So we covered a little bit about the paper and the hypothesis of injuries being caused by movement.
Yes.
Which is a decent, reasonable hypothesis, but based on decades of data, that's probably not benefiting patients by.
Well, they couldn't find any. They found zero data that showed that there was benefit to that, or that spinal mobile restriction decreased the possibility of a secondary neurological deficit.
Yeah.
And they talked about the hypoperfusion more than possibly being the cause.
Correct.
That's, like you said in the first part, there needs to be more research done on that theory, right? And we're not suggesting that. We're saying that's what they talked about in the paper. But it makes a little bit more sense.
It does. And I think I agree with that hypothesis. I think that's probably the biggest thing, because I think some of the cornerstones of management of spine patients, spine injuries, and trauma patients is avoiding hypotension. There is some permissive hypotension with some of those hemorrhagic sorts of injuries and things like that, but avoiding hypotension is important, and then keeping the patient comfortable. We're not telling you that it's not important to avoid movement. No, it is.
Right.
But maintaining comfort and avoiding those situations where we could interfere with blood flow.
Yeah.
Or cause, and a lot of talk too about the decubitus ulcers causing that subcutaneous ischemia can cause the potential for an infection.
Right.
There's a lot of damage that these things cause. And then we also talked a little bit about it, but I think it's worth mentioning here too, is that just the over-testing of injuries that don't exist.
Right.
By wearing one of these things into the hospital, it's like your ticket to ride the CT horse. And it's like, I don't want to ride it.
Yeah.
But I get forced to.
Yeah.
And a lot of well-meaning physicians wanting to rule it out. But we'll talk a lot about what we can do clinically to rule out spine injuries in a bit. But I think it's worth talking about some of the management principles. I know we talked a little bit about some of the stories we'd heard.
Yeah. Well, one of the authors of this paper was on the EMS Avengers podcast, a friend of ours, Jimmy, and we listened to that podcast. And he is the doctor. Forgive me if I'm saying his name wrong. Dr. Abau, I believe is how you say it. Medical director out in Florida, and he has basically taken them out. If I understood his practice, he's pretty much gone completely away from them at his fire departments. And he had talked about like maybe just if you suspected a spinal cord injury, maybe putting a towel around their neck, comfort. He talked a lot about keeping the patient comfortable. He talked about one call that he was out when he was riding out as the medical director. I don't remember if it was an NVA, but it was a pretty significant mechanism of injury. He went on the call, rode with the medics to the hospital, did not put on a C-collar, and got to the hospital, and the ER folks are freaking out, like, why didn't you put this patient in a C-collar? And he's like, because there's no data. But I just, researched all these documents. And he's like, because there's no data to back up that it helps. And they, according to his story, they went over and immediately put a C-collar on this patient.
Aggressively. He describes it as... like a pretty abrupt.
We got to do this. Yeah, we're trying to restrict movement, so let's go crazy.
And in a bow or a bow.
Yeah.
Anyway, in
It's a
his
bow.
defense too, he talked about how the patient had this waxing and waning of consciousness,
Yeah.
and it was
In and
there
out,
was something going on, and he saw that, and he said, "Ooh, I'm not going to put this patient in a C-collar,
Right.
and I'm going to do this because I think it's the best thing for the patient,
Yeah.
which should always be our goal."
Exactly.
And then in the hospital, and I agree with him. I mean, a lot of times we put on C-collars because that's the checklist protocolized thing
right.
to do with the trauma activation, and that's what the nurses are trained to do. That's what the trauma team.
It's been pounded into our heads.
And so they aggressively, almost like, hurry, put it in,
Yeah.
protect the neck.
Yeah.
And what happened?
According to him, he said she threw a clot and had a big stroke. And so go listen to his podcast. Go listen to the EMS Avengers podcast. You can listen to that. Great podcast, great information.
It is worth mentioning too that the C-collar is a unique part of the spine where the vertebral arteries run through the bones of the cervical vertebrae.
Right. Very common injury too. We people that crack their necks.
Yeah.
I've run on these people. We had a guy I worked with used to do that all the time. Sit there and crack his neck, and one day. And all of a sudden, they thought he was having a stroke at the fire station.
Oh, yeah.
They called activated a code, and transported him. And he had like deficit, all this stuff. And it was because he kept cracking his neck. And if I remember right, he was causing a weakness in those vertebral arteries. Yeah, it's not good.
Yeah, that's interesting.
So what are we doing with these things?
Right. Well, so if we do have a traumatic, we talked a little bit about this earlier. You get a blunt trauma. Patients maybe got a neurodeficit or tingling in the hands,
right.
From some sort of a cervical spine injury, and you're concerned about a possible fracture. Mm-hmm. This doesn't appear to be the answer, so I like what you said, is something comfortable, right? A comfortable way to immobilize a patient, to protect the spine. Mm-hmm. But again, immobilization doesn't appear to be the thing that's going to help them.
Yeah.
Avoiding hypoperfusion, maintaining our blood pressure,
which is what we're focused on with trauma patients anyway, right?
That's right.
Keep that map up. Keep your blood pressure. It doesn't. You don't have to have a blood pressure of 120, right? But if your blood pressure is 80, you probably need to be addressing that with fluids, blood pressure, something like that.
And it's worth mentioning too, the spinal shock is a real thing, and this is obviously not necessarily the cervical. I think it's more thoracic, but. Is when you've got a tremendous blunt trauma with a spinal injury, you can have that spinal shock pattern to the vitals, the hypotension and bradycardia.
Right.
You see that, obviously you can see the same thing with like a beta blocker overdose, and there are some situations, but in the context of trauma, it's really important to get those fluids up. You may even you need some pressors.
I was going to say, pressors are going to certainly help you get that vasoconstriction, because with those spinal shock patients, you're going to get a lot of vasodilation.
That's right.
Right, so the pressors are going to help Levofed. You're going to get those vasoconstriction along with the fluids.
Unopposed parasympathetic.
Right.
The autonomic nervous system gets all wackadoo.
Yeah, it's not sending the signal to, hey, we got to increase the heart rate here because our blood pressure's dropping. Nope, we're going to keep it at 50.
The brains of the autonomic nervous system are in the thoracic spine.
Right.
And that's the key there. But management of these patients is not to include the C-collar anymore. It's not the standard of care. And so maintaining patient comfort, maintaining blood pressure should be a management priority for us.
I have a question for you from a medical director.
Yeah.
And I didn't even ask you this beforehand, so this is an unfair, on-the-spot question.
I love it.
But as a medical director...
I've always promised I'd never do that to you.
I know, you have, and I hate it when you do it.
Have I done that to you?
Oh, no, I don't know.
I'm sorry if I do.
Oh, no,
nobody
it's fine.
likes to get a question they're unprepared for.
Well,
I
think that this is not something that you should know, because this is a new thing. So I'm not asking you something that, if you don't know this, you're in trouble. My question is, as a medical...
I'll say something real quick.
Go ahead.
Is it something we don't talk about this enough? Because oftentimes when we're teaching, and when I'm teaching a group of firefighters, nobody wants to look like an idiot.
Of course.
But I think it's really good. I've found as a physician, for me, some of the most powerful moments I've had is when I've not known something, and I've learned something, and I've
100%.
admitted I was wrong.
100%. And that needs to be, that's, when I'm teaching, not to get, we're squirreling here, but when I'm teaching, I want to create an environment of There's no stupid question now, but that takes time and trust. You can't do that the first day you go to the
Safety,
department.
yeah.
You know, if somebody says something that's kind of, you know, most people will be like, well, that was a stupid. Like, no, man, it wasn't a stupid question. Like, that's what you thought. Maybe you were taught incorrectly. Who knows, right? But you had the guts to ask the question. I'm not going to embarrass you over that question. Let's discuss it, right?
Anxiety in the learning environment
Should not
a
be
cancer.
there.
Should
That
be.
is, we say it on the fire ground all the time, is that, hey, this is where you make the mistake, right? You make the mistake on the fire ground so you don't make it on at training, so you don't make it on the fire ground, right? Same thing with CEs, right? Ask the dumb question in CEs. That way you're not making a bad clinical decision on your patient.
Totally agree. Sorry. Go, ask
No,
your question.
you're fine. So, but
It's
again,
important.
this isn't something that you should know. This is what is your opinion on something.
right.
So, as a medical director, I go on an MVA as one of your firefighters, and my patient is unresponsive in a car. We're extricating the patient out. Typically, we would, put a C-collar on. We would slide them onto a backboard, maybe get a KED out, strap them into a KED, and then lift them out. What do we do now if this trend is moving this direction of we're not really worried about C-collars and stuff? What would be the process there, in your opinion, right now?
Spinal immobilization or spinal motion restriction using backboards would be appropriate with extrication.
Okay.
I don't know that a C-collar would necessarily be needed if you've got them on that backboard and you've, for patient safety, you've secured them to that backboard just for extrication. You get them to the gurney.
Well, but you usually are using the backboard. We're sliding it under their butt, and then if they're still sitting in the seat, upright, somebody's holding it from the back, and then we're rotating them, laying them on the backboard simply to get them from the car over to the cot.
Yep, I hear you say. Yeah, and I think there's a certain amount of motion we can't avoid.
Exactly.
Yeah, and I if I was on that ride out with you in this patient's situation, I think I would limit the motion as much as I could.
Yeah,
and
okay.
get them into an environment where we get them onto that gurney safely.
Okay.
Away from the accident in a comfortable, in a comfortable position as much as we can. I would not place a C-collar on that patient unless I had a really good reason to. There are some, I would consider it in maybe that really old osteoporotic patient, maybe there might be some evidence there that might, there could be a study that comes out in 5 years showing that in women from nursing homes that have terrible osteoporosis, men can have it too, but it's typically women, terrible osteoporosis, maybe those fractures can be more unstable potentially.
Sure.
I know in Down syndrome patients, there's a lot of cervical spine abnormalities that are congenital associated with that genetic condition, Down syndrome, that create some serious cervical issues. There may be evidence that in those patients, a cervical collar may be more beneficial. Maybe there could be data that would come out to defend those things. But for now, based on what we're seeing, I would do a towel, that vacuum, some sort of inflatable device that I could try to in maintaining patient comfort is to keep them still and if motion isn't causing any harm, restricting their motion actually may not be the answer. I would be focusing again on patient comfort, treating their pain, and maintaining blood pressure.
So in the car, am I still holding C-spine? Am I still holding their neck as we're removing them from the vehicle to try to keep it in line at least?
Yeah.
Okay, so you're still doing that part, but not taking the C-collar out of it, but just keeping some spinal.
Yeah, maintain that position of comfort. Try to restrict motion as much as you can. I'm not saying be afraid of touching the head.
Right.
Because you wouldn't want the head
bobbling. Right.
I think, and I know you know that, and I think that would be. I would try to limit motion. I mean, that's.
Okay.
I think that with any traumatic injury, we don't want to exacerbate things, and I think in an abundance of caution is to try to decrease the patient's movement. Just like you wouldn't want a patient to just get up and walk to the ambulance.
Right.
You're going to carry them over because they've significant mechanism.
Right.
I think the same thing is true for any sort of potential spine injury.
Yeah.
It makes sense logically to.
So we're not doing
movement.
the C-collar as they're standing up, and then the backboard behind the back reaching through and dropping them on the ground like we used to do.
No.
Yeah, we're not doing that anymore, which is good.
Yeah.
Which is good. Okay, good. I was curious about that, like the KEDs. Again, that MVA patient, maybe unresponsive in the car. How do we handle that now? And again, we're not. You have to get with your local medical director. This is going to be protocol change and all kinds of stuff. But it's an interesting.
It is interesting. It's turning it all upside down with the way we've done.
Not the
things in
patients,
past.
the information.
Yeah,
mindset.
not the patients,
don't turn your
please.
patients upside down. That would be bad. But no, I think it's great because, like I said, I have hated, and I think most people, they hate putting these C-collars on because. You got little old grandma, my protocol, 65 years in age and over with any sort of mechanism of injury. And so, you get 80-year-old grandma fell out of bed at the nursing home and we're taking her in because the nursing home staff wants her transported. And I've got to put this collar on her and it doesn't fit right and it's up over her ears or it's popped up over her chin into her mouth and she's uncomfortable. I'm like, this is stupid. Yeah. This is dumb. I'm not doing it. Yeah. Then I get to the hospital and the doctor's yelling at me because, why didn't you put her? Doc, she slid out of bed onto her butt. Yeah. I don't think she needs a C-collar. But it's just like you said, it's this stigma that you have got to do this in these patients. And thankfully, we're actually using our brains to say, wait a minute, there's no data to back up that this helps or that movement is causing problems. That's so what correct. Are we doing it for? Yeah. I like that.
Totally agree.
Yeah, I think a lot of times when we have these protocol changes, I get questioned all the time. Like, well, what are we doing this for? I think a lot of people will like this change that we're actually taking something out as opposed to adding something
That's
to
right.
your protocols.
That's interesting.
But this is why, because the data says it's better.
I think, unfortunately, though, it's going to require a better exam.
Okay.
And we'll talk about that in our last segment here. But what do we do now moving forward?
Okay.
How do we handle these patients? And as a medical director, I look forward to sharing my plans with what we're going to do. And it may change. Mm-hmm. I may have to adjust and pivot based on what my colleagues do in the area and what
the
literature
data shows,
comes out.
yeah.
Right, exactly. But based on this data, I'm making some changes. And moving forward, we're gonna handle things differently in my fire departments.
All right, well, let's get to it.
So where do we go from here, Matt? What am I going to do?
Yeah, you're the guy in charge. You're the guy dictating what I get to do pre-hospitally.
Well, I think, in your position as an EMS captain, you're interfacing with your medical director at your municipality and your fire department very closely to try to, what do we need to implement to improve the safety of our community?
Right.
Because if it's true, just throwing a C-collar on every trauma patient we see isn't helping anybody. It's hurting them.
Yep.
So where one of the places where I'm the medical director, we are going to no longer use C-collars.
Period.
Well,
like totally, or?
Yeah, we're not going to use the C-collars anymore. We'll have them if we need them.
Okay.
So clinically, if there's a situation where my paramedics feel like they need to have a C-collar for some reason, they can use it. I do have some pearls in our protocols, like the Down syndrome patients or someone with severe osteoporosis, where and honestly, I don't think there's any evidence to support doing that. But clinically, these are things that can increase the risk for cervical fractures, right?
Sure.
Neurodeficits and things like that. But based on this evidence, I don't think that these C-collars are going to help anybody, even with that fracture. Now, I don't say we let them move around willy-nilly.
Right.
We're just going to protect their spine, just like we would protect any patient, but maintaining comfort. The C-collar isn't the answer for that.
Yep.
But the one thing that I am also doing is that the Nexus criteria. These were developed in Canada. I think they were developed in Canada.
We pulled it up right here.
Yeah.
It's the Nexus, NEXUS, National Emergency X-ray Radiography Utilization Study.
Correct. And so this is a standard of care for clearing somebody's C-spine in the emergency department. But I think it's good information here. If we're not going to use C-collars, we better document things really well.
Yeah, our
Make sure-
assessments really.
right.
Yeah.
Your neuro exam has got to be on point.
Don't just click all no abnormalities in your flowchart in ESO.
Right.
Please stop doing that.
Because if you don't have a good neuro exam
Yeah.
and you don't put on a collar, and then somebody
Yes,
has a neuro deficit documented later,
Yeah.
you look pretty bad.
Yes.
But if you've documented your neuro exam and this patient has no neuro deficits, no strength weakness, nothing, no sensory deficits, and
Right.
you've documented all of that, a certain percentage, a significant percentage of spine injuries do happen over time after the initial insult. So it's reality, and that's why they hypothesize that motion caused those
Right,
things.
right.
These things happen,
Yeah.
but it's based on what we're seeing here. It's not motion.
Right.
Hypoperfusion. We talked about this.
Right.
And so when we're dealing with a spine, a trauma patient, blunt trauma, likely, we are going to want to document our physical exam. Part of that is going to be the first component of Nexus is the midline tenderness.
Yeah.
You know, are they tender?
Palpating the neck. Yeah. Do you feel any pain here?
Whoa, it really hurts.
Yeah. Oh, don't touch that. Oh, that hurts.
Right.
Yeah, exactly.
And I'm telling my guys, don't put a C-collar on.
Yeah.
But maybe a towel or the vacuum splint just to keep the patient comfortable and to limit the motion. But the C-collar to limit the motion, I'm not doing anymore.
Even if they have point tenderness.
You didn't have point tenderness.
Okay.
Now, I'm in discussion with some other medical directors, and one thing that is true when you're changing things drastically, you don't want to be the only one doing it.
I was going to say, yeah, that's
So
same thing my medical director said.
Yeah. So I think there's going to be some collaboration here.
Sure.
And things may change when we actually implement these on, actually just in a couple weeks.
Right.
We're going to implement these and add these directives to the protocols. But that midline tenderness is important to document. And paraspinal tenderness is tenderness just to the side of the spine,
Right.
which is common. Those muscles, like we talked about.
Sure,
can
get
tighten
tight,
up.
whiplash. Type,
Yeah. There's supposed to be a curvature to the spine. It's called lordosis. And as sometimes when you've seen those older folks where the curvature goes the other way, it's called kyphosis,
Yeah.
correct? But that lordosis is the way we're designed, and when we get that whiplash injury, it can straighten that cervical spine, and it's because of those muscles.
Yeah.
So anyway, the point is, on your physical exam with these patients, document where they're tender.
Yeah.
And if they are tender in the cervical spine, I'm gonna have them pay special attention to that and make sure they've documented their physical exam and make sure they protect the spine as much as they can and keeping the patient comfortable.
Got it.
We don't want to cause that hypoperfusion. It seems to me to be a more realistic and more reasonable hypothesis to what's causing some of these post-incident neurodeficits.
Right. Maintaining blood pressures, maintaining maps. It talks about in here that's the one. There's 5 criteria with this Nexus criteria. No posterior midline cervical tenderness.
Yeah, went them all. Yeah.
2, no intoxication. So obviously, if your patient is under the influence of alcohol or other substances, right, that could numb their senses and they could not be feeling any pain. Right, and obviously this is in the context of a patient that's has a mechanism of injury, right? So DUI. You go on, which super common call that we all go on. We go on a wreck and somebody's intoxicated, which is the cause of the wreck, and there's a lot of damage. Those patients you need to use extra caution on because they might not be feeling any pain in their neck, right, or any other pain, right? And so again, not necessarily putting them in a C-collar, but cautiously moving them to the cot, putting them in a position of comfort, maintaining their vital signs, and documenting a good head-to-toe assessment.
And it's tough with these intoxicated patients.
Yeah.
They're oftentimes combative.
Yeah.
And, a combative patient.
That's why I love ketamine.
I know. Yeah, well, I mean, that's the key, right? I mean, there needs to be more literature studying some of these patient populations, but putting someone in a C-collar is causing harm, and I'm not sure it benefits these patients.
Yeah.
So lots
Why are
of
we doing
discussions.
it? Yeah.
And I've had patients too that are altered or they're angry when they put the collar on and actually move more and fight.
Oh yeah, that's what we talked about in the last part. Oh, 100% grabbing at it, pulling. We just had a patient the other day that got hit by a car. He was riding his bike, got bumped, got bumped by a truck. But he had a pretty good hematoma on his head, bleeding, He was a little altered, and we put the C-collar on him, and he wanted that thing off. Take this thing off of me. He kept pulling at it, yanking at it. The medics, work, because that's what's ingrained. You got to keep that collar on. So hopefully we can go away from that. And which brings us to our next point, normal level of alertness. Like this guy didn't have a normal level of alertness. Yep. He was like A&O times 1, maybe 2. Yep. Like he was a little bit confused on some things. So that would be a patient, again, that we would cautiously move per your recommendation to the cot, put a towel around their neck, something like that. And again, monitor vitals, resuscitate if needed.
And get them to the place where they can get the imaging done and really ascertain what's going on.
Right.
And a lot of these things can't even really be seen on an X-ray or a CT. It's going to need an MRI. Right. So, and we'll let those neurosurgeons and those trauma surgeons.
Let those really smart people figure it out.
That's right. Us, we're there in the pre-hospital environment. And then the ER is kind of where I am. I'm kind of the interface between the two. You guys are that crucial 7 to 10 minute time.
We like to call ourselves the tip of the spear.
You are. And then I interface the patient you give me with the experts that can fix it.
Yeah.
But I think with an altered patient, you got to be careful.
Yeah.
Document the heck out of it.
Yeah, definitely a patient that you want to, because we don't know what's going on. Why are they altered, right? Yep. Again, we talked about intoxication, but do they have a concussion? Do they have a brain bleed? Do they have, things like that? So be looking out for that.
Distracting injuries, that's the fourth one.
Yep, that was in our protocols, right? If they had a distracting injury, C-collar. Got to get a C-collar, right? Because you got a broken femur. You're sitting there. They're hurting that femur, they're going to be moving around. They're not paying attention to that spinal pain.
So I think it's good clinically to be aware of that. That's a normal physiologic response. When you got tons of pain, your arm's been cut off, you may not feel that hangnail anymore.
Yeah,
I mean, this makes sense. But so if you do have that distracting injury, that physical exam is going to just have to be all the more careful.
Yeah.
And I think the last one is when you do that neuro exam, which is important for anybody with a potential spine injury, document the strength.
Yep.
Right? Equal grip strength.
Yep.
Moving
their feet.
Exactly.
Yeah.
All that, document that. When you have somebody the grip strength and pushing the feet down, those are some of the longest nerves in the body that are starting up at the brain all the way down to the hands and feet. Yep. You're in sensory too. You want to sensory. And if you want to do a full neuro exam, go for it. Just
go ahead and do the
Babinski.
Babinski.
You've been told.
If you want a Babinski, go for it, bro.
That's funny. No, but I look for those neuro deficits and document that there are none.
Yeah,
Got to do that.
Yeah, again, documentation super important. Especially as we're transitioning away possibly from C-collars, in which it looks like that's the direction EMS is going, is that we're probably going to be moving away from this. So, make sure in the interim that we're documenting well, because even the general public, I would think, knows about C-collars, right? I mean, it's not like some hidden secret. Everybody's seen this, in the TV shows and things like that. And so, documentation is going to be super important.
It's kind of like a pupil exam.
Yeah.
I know that a pupil exam is something parents expect, so I'll do it. Looking in the eyes.
For trauma patients, you mean like if they come in with
a kid comes in, if I don't look at the eyes, I know there's a significant number of mommies and daddies who are going to say,
is that not a good exam?
No.
Oh, I didn't know that.
I mean, do it, but it doesn't. I mean, I know that a herniation is a late finding.
Oh, that's true.
If I'm seeing herniation,
and you're going to see
If I'm seeing herniation on my pupil exam, I probably intubated the patient already. Right. So
they're going to have other signs like Cushing's or something like that. Yeah.
You could have what's called like an abnormal pupil or something from like a traumatic iritis or from head trauma, like a bar fight or whatever. Right. But that doesn't mean you're herniating. Yeah. And a herniation is a late finding. Yeah. And
it's kind of like tracheal deviation with a pneumo, right? Yeah. I've heard that like almost nobody's ever seen that.
I've never seen it.
Yeah.
I've never seen it. But the whole pathogenesis of increasing ICPs, and we're not talking about that today here. Right. But it's kind of like C-collars, right? Yeah. I mean, it's like this C-collar is just kind of something we just do, but we don't think about it.
Makes us feel better.
It does make us feel better.
When we put the C-collar
It's almost, and I've been there in the ER when I have that trauma patient that walked in an ATV accident.
Yeah. Get him in a C-collar.
Right,
Yeah.
right. And I feel like, and I think we can all identify with
Did
this.
the right thing for
the
my patient.
checkbox.
Yep.
It's like, okay, I can take that off my list.
Yeah.
It's kind of like the trauma progression. You go,
Yes.
okay, patient's talking to me, airway's good, breathing's good.
CABCs.
Right. I move on to the,
Or-
so this helps me to move on in
Yeah.
my progression of assessing a trauma patient. Okay, check that box, got the cervical spine taken care of.
Yep.
Actually, I've just increased the risk of injury.
Yep, exactly.
And that's the way we got to look at it. And it's going to take some time.
And we're lowering on the priority scale what is actually could be causing the secondary injury, right? We're not looking at, well, what's the blood pressure? What's their map look
Let's
like?
prioritize that. Let's prioritize those the blood pressure, our physical exam, patient comfort.
And a lot of times we don't do these good assessments because we put them in a C-collar.
That's
We're
right.
like, well, I'm immobilized their spine, so I don't need to check, if they've got movement in their feet because I've already done everything.
I've had patients ticked off because of the cervical collar. I'm like, I walk in and I say, "Sir, are you doing okay? You feeling any better?"
Get this dang thing off me.
Yeah. Like everything's fine except for this thing you put on my neck.
Yes, I feel like I'm choking. Yeah.
Now, I'll say this, though, too, as we kind of finish this out here, is that nothing is simple in medicine.
Nope.
And we're not looking for that thing where we just always don't use it.
Right.
That's not.
Nothing's
does not
100%
exist.
is what I usually say.
We don't want to overreact, and we got to be careful. But this is a pretty reliable piece of information here we see, and I don't think it would be prudent, and it's not wise, and it's not good for our patients to not change what we're doing if we're putting C-collars on everybody.
Yeah, like I said, I will put a link to this. It'll be in our link tree. You can find that on all of our social media and everything. I'll put it in our YouTube video for this podcast. You can click to that link and get to this article. Read the article. I think sometimes, too, a lot of EMS providers, we're not like you guys.
Yeah.
You guys read a lot of research as physicians, and we don't do that much. It's not really ingrained in us to read research, but this is a really good one that's going to have a lot of impact on what we do every single day as EMS providers. So read it, and then take it to your medical director. Make sure that they are aware of it.
Do we have time for 1 minute? 1 minute of advice?
Go. Ready? Go.
I have 30 seconds.
Yeah. You're wasting time.
Because you and I talked about this. I think it's important to, like when you read a paper, figure out what the purpose of the paper is first.
Oh, yeah.
And then understand what is your purpose? How does this affect you and your job? And then after that first P, you go to the second P, which is to peruse. Look at go look through it and see if you can find problems. Mm-hmm. See if you read it and something doesn't make sense.
Yeah, try
so
to
you read
deconstruct
how
it.
many people were in this study? What kind of study is it?
Right.
And then
Were
finally,
they trying to sell something related to the study?
Right.
Yeah, was
and
there?
then, and then ask yourself the last P, which is practice. How does this change my practice?
Right.
Just do that. And then ask your medical director, hey, I was looking at this study based on what I read. This is what I think. What do you think? Can you read this? Mm-hmm. I would love it if one of my paramedics or EMTs or firefighters did that for me.
Yeah. Yeah, it's a different way to learn, right? Mm-hmm. And it's then you'll start to understand why protocols change is because of research and data.
Exactly.
And that's what you guys, like I say, you guys are ingrained in that. It's not really ingrained in the EMS.
It sounds complicated,
world.
but it's really not that hard. The 3 Ps, really.
Yeah.
You just
Well, like
know
anything.
your purpose, peruse the paper, ask questions, look for problems. And the last P, of course, is the practice. How does it change your practice?
Yeah. Well, it's a good podcast. Maybe we'll go away from C-collars for the majority of our patients now.
Be safe out there.
See you on the next one.
Thank you for listening to EMS, the Erik and Matt Show.